So Dr. Gilbert asked me to have a lecture with you guys to kind of talk about ICU pharmacology, which is kind of an intense thing to try to squeeze in. But in theory, I'm supposed to cover sedation and delirium management, pressors, and empiric antibiotics in the unit. So we kind of have to go through this fairly quickly just to get through everything, but please interrupt if you have questions. And then when we talk about the pressors and inotropes, I kind of just take it as more of a practical approach because I think you have a shock talk on Friday, and Dr. Gilbert will talk more about pressors in that lecture as well. All right, so we'll open with a case because I think it's easier to tie it to a case. But JS is a 75-year-old female with hypertension, diabetes, and dyslipidemia admitted for septic shock secondary to CAP. She gets tubed in the ER because of acute respiratory failure. So you get called by the ER nurse wanting to know how you're going to manage the sedation of this patient. So what are some things that should roll through your head when you're thinking about this? What do you want to know?
She have any allergies?
Great, allergies. What else?
How big is she?
How big is she? Okay. What else?
What did you get for induction?
Yeah, what'd she get for induction? That's helpful. Do you think it's a thorough past medical history? Is there any, maybe there's psychiatric conditions missing or social history missing? You want to know some of that to see if there's drug tolerance in the past. Do you want to know anything about her hemodynamics? Okay, so yeah, we'll get more into that. How about what she's doing right now? Like, is she moving that you think she needs sedation, or can we hold off and not do anything at all and just kind of watch her? So before you start thinking about sedating anybody, you want to make sure that you've given a thorough assessment of the patient, because we blindly put fentanyl and VaSST on everybody every single day, and these drugs are not without risk. So you really want to make sure that they are medically indicated before you start them. All right, so these basic definitions are just for your review, but the difference between analgesia, sedation, agitation, anxiety, and delirium is actually really important because we use different drugs to treat each one of these conditions. So I don't want you to leave the ICU thinking that you just blindly sedate people. So you are treating these constellations of symptoms. You're treating pain, you're treating agitation, and you're treating delirium. Think of each one of those as separate entities because the drugs you give are very different for each one. So we kind of break down from here on out and break it down by that pain, agitation, and delirium because that's how the brand new guideline actually breaks it down for you for your reference. So pain in the ICU. About 65 to 80% of your ICU patients are in pain at rest, and sometimes it's really obvious things such as trauma or burn patients, or acute post-op, but keep in mind that when they survey ICU patients who survived their ICU stay, the things that they recall being the most painful are actually the routine turning, suctioning, and wound care. Those are what patients recall the times that being more discomfort. So anyway, it's important, and you get used to the things that you do to these patients, but it's not routine to them. So the new pain, agitation, delirium guidelines came out in 2013, so they're hot off the press, and they were the first guideline update in 11 years. So I kind of have a comparison of what the 2002 guideline recommended compared to the 2013 recommendations. All of these recommendations are board exam worthy for medicine boards, critical care boards, whatever. So it's kind of important that you at least know what this guideline mentions because it's the governing body for all pain, agitation, and delirium management across the globe. So in 2002, they said that you should be assessing for pain, and it might be a challenge to assess for pain in a vented patient. That's pretty vague and not helpful, right? So 2013, we actually have some evidence-based answers. They recommend that you should assess for pain, and the gold standard, even if you're intubated, is still to do a numeric rating scale. However, recognizing the fact that there are challenges to doing a visual analog scale, they recommend the BPS, which is Behavioral Pain Scale, or CPOT. I forget what that one stands for, but anyway, those two tools can be used in conjunction with a numeric rating scale to help assess pain in ICU ventilated patients. They suggest against the use of vital signs alone as an indicator of pain, but that those vital sign changes, so if they become tachycardic or hypertensive and they're not normally, that should be a cue for you to begin further assessment. In terms of how you treat pain, the guidelines recommend opiates back in 2002, and then they had a lot of specific drug recommendations on when you would want to use each type of opiate. They really tried to like map it out for you. This is the population you want to use fentanyl. This is the population you want to use morphine. Contrast that to 2013. 2013 says that you should use the strategy called Analgesia first sedation. What that means is that you treat a patient's pain first. And if at that point they are no longer agitated, then you stop with your treatments, because we know that benzos and propofol and even dexmedetomidine are associated with side effect risks. So they say if you can get away with treating the pain and they're not agitated on top of that, that you'll be better off in terms of bigger outcomes. If you're going to treat, they recommend using opiates, but they said to just base it specific to the patient. So they kind of backed off on when you're going to use what agent and sort of left it up to your expertise. And then they did make a recommendation on neuropathic pain, which is interesting. So what do we do here at Loyola? So this is kind of a summary table of what we have available and how we dose drugs at Loyola. If you go somewhere else, you might find different dosing ranges. So these are not meant to be absolute, but it's meant to be sort of a reference point. So we use fentanyl first and foremost, and for good reason. We dose it in mics per kilo per hour if you do it as a drip here. So 0.5 to 9-ish is kind of your max range. You can give it as intermittent pushes, and in that situation I like to do 25 to 200, somewhere in that range. And you can dose that as frequently as you want, as long as you have a protected airway. So in terms of clearance of fentanyl, it's metabolized through CYP3A4, so that's the more common hepatic CYP enzyme, so it's subject to drug-drug interactions, certainly. For concentration of drip here, we only have the one concentration. It's a 2500 mic in 50 ml, which means that it's straight drug. So I probably could count a billion times how many times I get asked, like, can we concentrate the drips anymore? This patient's fluid overloaded, Erin, and you can't concentrate the fentanyl anymore. It's straight drug. So anyway, we use fentanyl because it's thought to be the most hemodynamically safe of all the narcotics, right? So it's pure synthetic opiate, so it doesn't cause as much histamine release as any of the other opiates, so that's why we favor it in terms of using any other analgesic. In addition, it's thought probably to be the shortest acting out of any of them, so it's quicker on, quicker off. The one exception to that is remifentanil, but of course we don't have access to that here. So when is fentanyl maybe not such a good option? Unfortunately, patients get really tolerant to it relatively quickly, and that has to do partially because of how it's dosed, but it also has to do with that it's very lipophilic. So your tissues fill up, saturate, and then you stop responding to the doses that you responded to before. So in that situation, you can turn to drugs like hydromorphone or morphine. If you do a hydromorphone drip here, we start in the range of 0.5 to 1 milligram per hour, and I've seen up to 20 milligrams an hour. These are relative max ranges. But you can also do intermittent pushes, so 0.5 up to 4 to start, IV push, and again, as frequently as you want, as long as there's protected airway. Hydromorphone and morphine, both are hepatically cleared, and then I noted that there's an active metabolite with both of those that's then renally cleared. So what that means is you have to care about both organ systems, and that is not benign. I can't tell you how many times in my short career that I have seen patients get transferred to the unit purely because they got too much morphine on the floor and had to get intubated. So you got to really pay attention to how frequently and how high your dosing is in your elderly patients or anybody with an organ dysfunction. And then I just mentioned remifentanil, so you have access to it. It's a nice option that's kind of on the horizon. They use it a lot in anesthesia. The thing that's appealing about it is it's short-acting and purely synthetic like fentanyl, but then it's cleared via plasma esterase, which means that it has organ-independent clearance, which is kind of nice in your patients that are in shock. The guidelines do recommend that you consider non-opiates for pain, but unfortunately a lot of our patients have a contraindication, or at least a relative contraindication, to giving acetaminophen or NSAIDs, but those are just listed there for your reference. Questions about pain before we move on?
I have a question. So
Yeah.
I've had quite a few patients who
developed opioid overdose or whatever, like hours and hours after they got
Mhm.
morphine, like people who had renal dysfunction, they were totally fine up until that point. What would cause that? I mean, is it because it's not metabolized yet?
So it could, yeah. So morphine, remember, goes from morphine to morphine 6-glucuronide, which is through the liver, and morphine 6-glucuronide is actually just as pharmacologically active as morphine. And then that metabolite's then renally cleared. So it all kind of depends on where that patient is in terms of how much they're converting and then how much of that M6G they're retaining. So it's not unreasonable. Like, we have our lady in 34 who got sedation like a couple of days ago. I mean, and maybe at that point I'm less inclined to think that this is drug-induced, but it's not unreasonable to think that any time within a 24-hour period, if you have an organ system down or you're old, that it could be related to the drug. So if there's no contraindication in that situation, you could try a little bit of Narcan and see what happens.
And is there any difference between morphine and Dilaudid in terms of safety? Like you said, they're
Safety
both
profile?
renally.
Yeah, so what's interesting about hydromorphone is even though the textbook answers that there's an active metabolite that's unrenally cleared, I tend not to see as much drug accumulation affecting those patients. So if they're intolerant to fentanyl or and you need to switch to something else and they have multi-organ failure, I tend to see a little bit more safe use with the hydromorphone compared to morphine. I'm not really sure why that is, but it just doesn't have as big of a pharmacodynamic effect. So, good questions. All right, so then kind of moving on to agitation. So like I said before, if you treat a patient who's ventilated, adequately treat their pain, that's kind of the best approach. And what you'll find is in clinical trials, when they do that strategy, only about 50% of the time do you actually need to add some sort of sedative agent to treat their ongoing agitation or anxiety. It's definitely a very difficult balance to achieve, right? So we know that patients who are comatose are associated with worse outcomes, such as those listed there. But at the same time, if they're overly agitated, that's not good either. So they have more adrenergic output, which isn't good for their whatever's going on that brought them to the unit in the first place. They're combative. They have procedures held. You guys have to keep putting in new DAB-HOFs and A-lines and things like that. So that's not good either. So how do we achieve this fine balance? In the guidelines, they went from monitoring using the SAS, MAS, or VICS to switching to the RAS or SAS. We're going to go into RAS in a little bit more detail, Richmond Agitation-Sedation Scale, because that's what we use here at Loyola. Back in 2002, we actually only had benzos or propofol as an option for sedation. And at that time, they recommended basically just ignore the recommendations. They're bad. But in 2013, we kind of discovered in this decade that maybe benzodiazepines are associated with worse outcomes compared to non-benzos, and that actually did pan out in the guidelines. So they do suggest, it's not a strong recommendation, but it's a suggestion that in most patients, a non-benzo regimen such as propofol or Dex is probably preferred over benzo. And then they don't make a comment on in terms of if you have to use a benzo, is it better to use an infusion or an intermittent push? And then, interestingly enough, daily interruption or a light target level of sedation is recommended in the 2013 guidelines, and they actually really emphasize promoting the sleep-wake cycle to kind of help limit the need for sedative agents. So we do practice the daily interruption here, so we'll talk about it a little bit more. So this is Richmond Agitation-Sedation Scale. How many people have used it or heard of it before? All right, good. So what you'll find is that it ranges in score from -5 to +4. Anything on the negative side represents increasing levels of sedation. So -5 is completely comatose. You don't respond to anything. And then anything on the positive side represents increasing levels of agitation. So +4 is that, alcohol withdrawal crazy patient that's swatting at you and they're harmful to themselves or harmful to staff. So where do you think you want your patient in this scope of the scale, if you had to guess?
0.
Okay. Yeah, so for the most part, we try to aim for a RAS of 0 to -2, and that's actually really hard to achieve. And I feel that our nurses do a fairly good job of it, but a lot of times I do see them fluctuate from being basically like a -3, where they don't really respond, but...
Five.
yeah, or they're like +2. And so it is definitely a difficult balance to achieve, and it will vary depending on when you're going to see the patient. But in general, you want 0 to -2. There's going to be exceptions to that rule, right? So what is the time when you think you need deeper level of sedation? Who can think of an example? When do you not want your patient alert and calm?
You're doing stuff to them.
Okay. So like patients that come back from the OR with open bellies, open chests, severe burn patients that are going to have wound care all the time, they're not going to be somebody that you want alert and calm. What if I'm on a paralytic? I sure hope you don't keep me at a RASS of 0, okay? What if you're on some funky ventilator setting for ARDS and you need them totally knocked out, not breathing over the vent? So things are going to come up that cause you to adjust this, but the point is every single day, everybody, providers, nurses, pharmacists, everyone needs to know what the goal is and whether it's appropriate or not. So how do we get there? So we have benzos, we have propofol, and we have dexmedetomidine. I'm going to skip phosphopropofol and etomidate derivatives. They're just there for your reference because that's kind of future directions of sedation practice. But so here we have lorazepam and midazolam for sedatives. We do Ativan drips, unfortunately. I try not to, but we do end up on them mostly in our alcohol withdrawal patients, and that's okay. But if you do it, it's 80 milligram in 500 ml bag. So it is a fair amount of volume that you're going to give them. And then we start around 0.5, maybe 0.25. And I've seen up to 20 an hour, maybe a little bit higher. The nice thing about Ativan is there is a PO equivalent. So in those patients that you have on continuous infusion sedatives and you can't get them off, and you think otherwise they're ready to go to some place like RML, they can't unfortunately go on continuous infusion drips. So a reasonable approach to that is to consider switching them to intermittent scheduled PO Ativan. So that's kind of why it is a nice option in that situation. So what, in terms of benzo side effects, what do you guys worry most about? Respiratory depression. Okay. So you need a protected airway to be on any of these strips. The one exception is alcohol withdrawal, but really you still need to worry about having an airway. Okay, what else? Dependence, yeah. So they get tolerant and then you need to go up on it. Do you think it worsens or improves hemodynamics? Right. So hypotension, bradycardia, we see that on the guy in the corner. Every time they go up on this VaSST, he gets bradycardic. And then delirium is the other big issue, right? So we know time and time again, clinical trials demonstrated that benzos compared to nothing, or even benzos compared to propofol or dexmedetomidine, are associated with higher rates of ICU delirium. Turns out ICU delirium is becoming a bigger and bigger deal in terms of survival out of the unit and even like long-term cognitive function down the road. So it is a big deal, something we often forget about, but something to consider. And then the other unique thing with Ativan is it is a propylene glycol diluent, so you can get propylene glycol toxicity. And how does that manifest? What?
you get?
Yeah, what do you get with propylene glycol toxicity? Yeah, so it's in your mud piles, right? So I don't monitor anything specifically other than if you started to see an unexpected gap and you can't figure out why else it's there, it might be Ativan
This is
related.
just Ativan, not anything.
Just
So
Ativan.
it's like a preservative or something?
Mm-hmm.
Yep. Again, what you get?
Propylene glycol toxicity, so anion gap acidosis.
Okay. What other than acidosis, what is there?
That's it.
So, what's her name? Mercedes have an iron here.
Mm-hmm.
Maybe that's, she got a lot of Ativan during the EGD.
It's mostly related with a drip over like long periods of time. Like I'd worry about it more so on the alcohol withdrawal guy if he was in renal failure, because right, propylene glycol accumulates in renal failure.
She got
So,
midazolam.
yeah.
So it's only in the drip, this preservative,
IV
not
form.
in the IV. Like,
Even in IV
pushes?
push, yeah,
Oh, just in
yeah.
IV.
But I see the toxicity more with drips. Like it has to be a pretty massive amount to cause an actual toxicity.
Not idiosyncrasy toxicity. Not
No.
some patients like allergic to it.
No, No, it's real.
What if you had a patient who was hemodynamically unstable, or you were worried about their blood pressure, and you needed to give one of these two categories? Which one?
That's what gets tricky. I think everyone responds a little bit differently, and unfortunately in the clinical trials, when you look at benzo-based regimens compared to non-benzo-based regimens, most of the time the hypotension and bradycardia side effects are about the same. The one exception to that rule is dexmedetomidine causes more bradycardia than any others, but we'll talk about why that is in a second. So unfortunately, I think it is a little bit of trial and error individual to the patient. What is nice, which we'll talk about next, segue into propofol, is that propofol is the quickest acting and the shortest acting. So if you get in trouble with hypotension and you turn it off, it's going to be gone in a matter of minutes, versus whereas pamidazolam accumulate in organ failure. So propofol, starting dose is around 2. Usually we start around 5, to be honest. You can go up to 100 mics per kilo per minute. Like I said, the half-life is really, really short, so like neuro really likes it because you can turn it on, turn it off. They're sedated, then they're off in a matter of minutes. So what's the issue with propofol besides hypotension? That's another issue. Who's ever seen what propofol looks like? Milky. So it's actually in a 10% lipid emulsion, which means that if your patient is on an average amount of propofol, let's say they're on 40 mics per kilo per minute and they're a 70 kilo patient, they get like a Big Mac in calories every day from propofol. And dietary will actually factor it into their 2-feed calculations for goal calories. So it's something to keep in mind. And so with that, if you're giving that much fat as an infusion on high-dose propofol, what do you think you need to worry about? So yeah, I hope you're not on it for long enough for that to pan out. But what organ can get irritated with too much triglyceride? Yeah, so pancreatitis. So you monitor the triglyceride usually every 48 to 72 hours when they're on propofol, and just make sure it doesn't get past that 400, 500 cutoff, whatever your threshold is. But I've definitely seen cases of pancreatitis with propofol. It's possible. All right, and then last but not least, dexmedetomidine. So this is a novel. Yeah.
Multi-organ failure if the patient stays.
So yeah, propofol has a side effect called PRIS, which stands for propofol-related infusion syndrome. It's incredibly rare, but there's a black box warning against it, so you should be aware of it. But essentially, what happens is propofol is very lipophilic, so it will penetrate cells and it will saturate those cells, and once it saturates them, it can cause mitochondrial shutdown. This is the theory anyway. And so that's obviously bad, right? So how that manifests is the patient abruptly goes into multi-organ failure. And unfortunately, there's really nothing you can do about it. You'd stop propofol and symptomatically manage them. They're going to have elevated lactates. They're going to have renal failure, liver failure, respiratory failure. They might have depressed EF acutely. So you support them, stop the drug, and hope they get through it. But mortality rates are upwards 80, 90%. The problem is when you look back at the case reports, everyone starts to question whether or not it was an underlying illness that contributed in the first place and not necessarily related to propofol. So it's out there and you should be aware of it, but it's rare. All right, so then dexmedetomidine, which is Precedex. So how does this drug work differently than the others? What's its mechanism of action? So remember Ativan, or any benzos and propofol, they're GABAergic, right? So that's how they sedate. But in acting as GABA agonists, they also suppress respiratory drive. So dexmedetomidine is novel because it's essentially acting alpha-2 agonist. So how does that work? Similar to what other drug do you know that does that?
Clonidine.
Yeah, so it works just like clonidine, but it's about 8 to 10 times more potent for that same receptor. So sometimes you have patients in clinic that you might give a first dose of clonidine to because you're worried about the possible sedating effect and you want to see how they do. Think of that times 10 with dexmedetomidine. So, but as a result, you get a little bit of sedation, but you don't suppress respiratory drive. So you actually don't need to have a protected airway to give dexmedetomidine. So when you give this drug, you dose it in mics per kilo per hour, which is a little bit different than some of the other dosing. There's potential for error there, so just be aware of that. And then in terms of side effects, So if it works like clonidine, what do you think happens? Yeah, and bradycardia. And you can almost predict that that's going to happen. And actually, some institutions will titrate dexmedetomidine to a % decrease in heart rate because they know that that's when there's sufficient amount of drug on board. So the times that we're using Precedex here, unfortunately, it's restricted to attending physician use only at the moment, and that's just because of price. But the times that we're using it are if you have some kind of paradoxical reaction to propofol or a benzo and you can't use those, or in the situation where somebody you think is ready to get off the vent, other than the fact that agitation is holding you up. Like you can't even do weaning parameters because every time you turn off the drips, they're 0 to 180. So in that situation, we have started dexmedetomidine because you can actually do weaning parameters on it, and you can actually even do like spontaneous breathing trials on it, extubate on it, and then discontinue the drug after they've been extubated and they're calm again.
So can you use this for heroin withdrawal?
So it's interesting that you say that, yeah, because they're the whole opiate and alpha-2 adrenergic receptor profile is very like intermingled, so to speak. So like for example, you can actually treat a clonidine overdose with Narcan, and no one's really sure how that works or why, but it turns out they're just related to each other, and they probably have some feedback mechanisms that we don't really know about yet. So it is thought to be a little, because it does have a little bit of an analgesic effect as well. So it probably does have some indirect effect on opiate receptors is the long and short at the end of the day. But it's not going to be enough to suppress any respiratory drive.
You get every rebound hypertension.
Yeah, so
Same
you
thing
can.
as clonidine.
Yeah, so it kind of self-tapers. It is a little bit longer acting. Like I don't like to titrate it more frequently than every 20 to 30 minutes, whereas with benzos and propofol, let's be honest, we titrate them every like 5 minutes. But with dexmedetomidine, it does kind of self-taper when you stop the drip, but I have had patients who are on like 1.5 for several days, and then we try to stop it, and they will rebound. So in that situation, I've done a few things where I've backed off on the drip over a period of time, and I've also bridged them with clonidine.
Okay.
All right, so then daily interruption. If you guys have dealing on service, which I don't think you do, but you really need to know this trial. He's like adamant about everyone knowing the daily interruption and light sedation. And actually, it's even earlier than these two Lancet papers. But John Kress was the first person to ever look at daily interruption. And that was done at University of Chicago, and it's in New England Journal. But these two trials sort of replicate it, and they're the more recent ones that sort of link daily interruption or a light target level of sedation to spontaneous breathing trials. And essentially what they found is that at the end of the day, less is more. So if you can wake patients up every day and it's not contraindicated, or if you can get away with no sedation whatsoever, it's better to get off the vent faster, get out of the unit faster, and whatnot. One of the concerns, which Dr. Dilling loves to bring up, is you would think you would have issues with self-extubation rates, and in clinical trials you do. So in the patients that have lighter target levels of sedation or more daily interruption, they do have more self-extubation rates. But the key fact is that reintubation rates have been similar in clinical trials. So at the end of the day, they probably were ready to get extubated anyway. All right, and then we'll just skip that for the sake of time. So then last but not least, delirium. So as I kind of alluded to, delirium is turning out to be a very big deal in a lot of ICU clinical trials. It's thought to affect 60 to 80% of our mechanically ventilated patients. And the reason we're not detecting it is that, remember, there's the three types. So there's hypo, hyper, and active, and then mixed, where they fluctuate between the two. The majority of our patients are thought to fall in hypoactive. So they're not actually overtly agitated and combative during their delirium phases, but they're more on the hypoactive spectrum. So if you don't try to screen for it, you're not going to detect it, essentially. So the delirium recommendations in the new guidelines essentially say that you should routinely screen for it. You should use CAM-ICU or ICDSC, and we use CAM-ICU here, so we'll go into that. We treat it with antipsychotics, but unfortunately the data is actually not that great even for using antipsychotics. They've looked at using antipsychotics prophylactically in clinical trials and found that that results in more harm, so the guidelines do recommend not to do that. And then early mobilization, as we know, if possible, is important. So this is the CAM ICU. Our nurses are supposed to do it every single day during the daily interruption. So you guys might get asked, well, my patient's CAM ICU tested positive, so what do you want me to do about it? This is kind of what they're referencing. So it's posted around the unit. Take a look at it when you have a chance. There's obviously challenges to doing it in a vented patient, but that's how it was actually first analyzed. So we try to do it every day, and then if it's positive, hopefully we try to do something about it. So this study is meant to just highlight the fact that antipsychotics really aren't the best treatment option, and you don't want to be blindly reassured that they're the treatment of choice. So of the clinical trials out there looking at antipsychotics for delirium, there's actually only one randomized, double-blind, placebo-controlled, multi-center trial that looked at an antipsychotic versus placebo for ICU delirium. And this is the one study. 36 patients, woohoo, and they randomized patients to Seroquel or placebo, up-titrated the Seroquel as tolerated, and they found that the Seroquel group's delirium was 36 hours on average compared to the placebo group's delirium was 120 hours on average. That's it. That's all you got. So yes, it's recommended that if you have delirium that you could consider antipsychotics, but the data is really not that great for using it.
That was Seroquel versus placebo or versus Haldol?
Placebo. Both groups were allowed to use open label Haldol for like intermittent agitation episodes. And then we obviously know early mobilization is important. All right, so you guys need to know basically that once you have a vented patient, use the order set only. Don't try to order drips outside of an order set because you're going to get paged, and soon enough they're not actually going to be available to order outside of an order set. The reason for that is purely so that you make sure to order the right monitoring that gets associated with being on continuous infusion drips. When you order the order set, it automatically prompts the nurses to do the sedation holiday algorithm. So it's out there in the environment for your reference if you need it. And then we kind of already talked about Precedex restriction. All right, so let's go back to the case, and now you're going to want to know how to manage vasopressor therapy. So you get a page that they've adequately resuscitated in the ER, which we can argue that all day, whether they did that or not. But let's say the blood pressure is low despite adequate fluid resuscitation. So I told you she's in septic shock from CAP, so what do you want to do?
I know what her blood pressure is.
All right, so her MAP is 40s. Okay, so you guys are asking good questions. So you kind of want to know a little bit more about what's actually going on with the hemodynamics before you just blindly order Levophed, right? And you also want to know, like, what access does she have? Like, can you order it centrally, or are you going to have to go place a central line? So what's going on there? But yeah. All right, so this table is totally overwhelming. I realize that, but it's kind of all-inclusive, hopefully a one-stop shop for everything you need to know about pressors at this hospital. So I'm not going to go through it in great detail because, again, Dr. Gilbert's going to talk a lot about shock on Friday. But what I do want to draw your attention to is on your table, what you're going to find is next to each drug is a concentration that's available at Loyola and whether it's pre-mixed or not. If it's pre-mixed, it means it doesn't have to come from central pharmacy. It means that it's loaded in the PICSA stations and all the ICUs and in all the procedural areas, so it will be there very rapidly for you to use if needed. If it's not pre-mixed, then it has to come from the IV room down in Central, which does take time, so it's not an immediate thing that the nurse can just start at the bedside upon your order. So the other issue to know is that the only pre-mixed medication pressor that's available on the floors in this hospital is dopamine. So normally dopamine is considered sort of a last line pressor at this point in terms of septic shock and arguably even cardiogenic shock at this point. But if you're on a floor code and you get the patient back and they're hypotensive, that's unfortunately your only option until you get them to the unit and get them stabilized. So you would want to start dopamine in that situation, and then once you get them to your ICU bed, then you can switch to whatever you think is indicated. Or, I mean, leave them on it if they're responding and it's okay, but obviously just know that that's the only way to get a pressor on the floor.
And that's in the crash cart?
Exactly.
Or on the floor?
It's in the crash cart. Yep. So
Is there a reason that we don't have Levo on the crash cart? Is it just because we don't really need it?
yeah, it's kind of interesting because the premix bags that we have here, you're actually very privileged. When you go other places in the country, you'll probably find that we only have dopamine available as a premix. So that is made by a manufacturer, whereas we buy premix bags of epi, norepi, and vaso from like a supplier. So they make it, but then it just has extended stability data. So it's short enough stability that it wouldn't be appropriate to keep in the crash cart because they'll expire before the crash cart gets used in most situations. But dopamine and actually dobutamine are an exception to that because they get made by a manufacturer and have like years of shelf life. So
like the other ones just aren't made by a manufacturer, or we just
Right.
don't get them? Oh.
right, they're just not made by a manufacturer, unfortunately. So yeah, take a look at this table. The dosing is listed there. The main thing to know about the dosing here in general for all the adrenergic pressors, so your dopamine, epi, norepi, phenylephrine, is that we dose everything exclusively in mics per kilo per minute. If you go anywhere else in the country, you might find that they do things in mics per minute or in mics per kilo per minute. So it will just vary. So what might be a high norepi dose here, you go somewhere else and say, oh, they're already up to like 2 of norepi, and maybe they think that's not a lot because they're not used to dosing it on a per kilo basis or something. So just kind of know what you're referencing when you say the dosing. Vasopressin use here, I listed the range of 0.01 to 0.04. We almost exclusively just start people on 0.04 and do not titrate it, and we'll kind of talk about that clinical trial. Do you guys have specific questions about this table otherwise?
Even they are not using it very frequently. Although twice you would usually use it.
Yeah, about epinephrine. So epinephrine use is actually really interesting because the Surviving Sepsis campaign was just updated in 2012, I believe, or 2013 potentially. Yeah, and they actually changed their recommendation to epinephrine as second-line therapy for septic shock, and previously it was like barely even mentioned in the guidelines. And that's not really based on anything. It wasn't like there was a recent clinical trial saying epi versus norepi, epi patients did okay. Like that's just based on the fact that if you can't use norepi, there's not a lot of other good options. So we're recommending epi based on expert opinion, essentially. However, we don't use it a lot because you see an insane amount of side effects with epinephrine. You get tons of tachyarrhythmia. You get a lot of ischemic limb. It does bump your lactates independent of any of the ischemia that it could potentially cause, and that's through an intracellular mechanism. So it kind of clouds the picture a lot. So we usually don't use it unless we're resorting to like 3rd, 4th, 5th options potentially. But in the guidelines, you're going to see it recommended second line. 2 ICU use of epinephrine, I would not equate it as a pressor because they're not using it as a pressor. Those patients are coming off bypass in the OR. They're using low-dose epinephrine to kind of stimulate the heart again, but it's not really that they're in shock per se.
Do
Because
they
they're
give
not.
pushes?
They'll give pushes
Or
here and
they use
there.
drips
They
to
use
make sure that
drips, but those patients are, I mean, maybe arguably in cardiogenic shock, but it's not like a true shock. They're not titrating that epi to a gold map or anything like that. They're using it to jumpstart the heart after bypass. All right, so the 2 trials to know about in terms of pressor use are the VaSST trial and the SOAP II study. So VaSST trial looked at why we use vasopressin. So this was a trial that randomized about 1,000 patients with septic shock who already required norepinephrine. So they took that group and they said, we're going to give you either additional norepinephrine or we're going to give you vasopressin. And Dr. Simpson already spoiled this trial, but essentially what's interesting to note is that the primary outcome of this trial was 28-day mortality, and they did not find a difference in their endpoint. So it's not like vasopressin is truly making a difference in mortality, yet it is recommended in septic shock. And why is that? So basically in the trial, you were able to get off adrenergic pressor far faster if you started vasopressin. And we know the adrenergic pressors are bad. They carry a lot of side effects. So if you can get patients off them, that's better.
Is there anything specific why? Was it like bowel ischemia, or was there one in particular?
Right. So they actually don't. I have to look back at that trial, but I don't remember them even looking at specific side effects like that, other than just signs of ischemia. I don't
So
remember.
when you take somebody off these pressors, you
Yeah.
take off the levo first and then the vaso?
Correct. So how it was kind of done in the trial, and there's a couple of follow-up studies that look at this, but in general, if you're on an adrenergic depressor, so you're on norepinephrine, you're on phenylephrine or dopamine, or maybe a combination of those two, you make the decision to add vasopressin. At that time, you start your vasopressin at 0.04. You don't titrate the vasopressin, but now you're going to try to wean off the adrenergic depressor. As soon as you can come off norepinephrine, then the nurse is going to try to start to just turn off the vasopressin. It's basically an on-off switch. You'll find that sometimes, depending on if you choose to micromanage it, that they'll kind of do their own voodoo, and they'll maybe go to 0.03, 0.02, 0.01, then off. But that's kind of up to them at that point. It's not something you really need to micromanage. But in general, the bottom line is start vasopressin, get off the norepi, and then try to get off the vasopressin. So the other trial is the SOAP II study. So just remember, this kind of justified why we recommend norepi over dopamine. But basically back in 2008, the Surviving Sepsis campaign said, well, you can use norepi or dopamine first line for shock. And then someone had a brilliant idea to do a randomized clinical trial of these two. So this was that trial. So it was almost 2,000 patients of all types of shock. So about 2/3 had septic and then 1/3 had cardiogenic. And they said, if you need a pressor, we're going to randomize you to dopamine versus norepinephrine. This trial found that there was no difference in 28-day mortality, which was their primary endpoint, but they found that there were fewer arrhythmia rates in the norepinephrine group compared to dopamine. So purely from a safety standpoint, they made the recommendation that norepinephrine is better than dopamine. In addition, in this trial, they have to allow open label use of pressors just because ethically you need to. So they found that in the dopamine group, there was higher open label rates of norepinephrine, implying that it is less effective, right? So more often you had to reach on the shelf to get norepinephrine in order to achieve your MAP goal. All right, so then last but not least is antibiotics. Yeah, of course.
Did they look at different types of shock,
Yeah.
like are those results just for everything, or did they separate?
They actually did break it down. What's interesting about that is the septic shock group, there was no difference still in the primary endpoint, but in the cardiogenic shock group, there's actually a trend in the improved outcome with norepinephrine. So. Okay, and then last but not least, this is a very difficult topic to sort of address in a few minutes, but so again, you have this lady with septic shock coming in with CAP, and now you need antibiotics. So what are some things that are thoughts that go in your head about how you're going to select her antibiotics? What do you want to know?
Allergies,
Perfect. Allergies.
hospitalizations,
Great. So I'm telling you CAP, but do you really believe CAP? Great. What else?
nursing home,
Nursing home. Okay.
Renal function.
Yeah. So how are you going to dose those drugs? Perfect.
And any history of infections?
Absolutely. Yeah. Exactly. So if you have a history of multi-drug Pseudomonas, then we probably want to cover that empirically. In terms of resources to go to, these are the things that I recommend doing. I know ID in general can be an overwhelming topic if you don't have an interest in it, but first and foremost, if there's an IDSA guideline on that particular organism or that particular infection, I go there first. So you can access that website free without any login at most of the computers at Loyola. So try to look into those guidelines at least, see if they exist and see what they say. Obviously, we have UpToDate available. For drug references, I tend to use Micromedics Clinical Pharmacology or Lexi. And then we do have access to the institution-specific antibiogram, which I think is helpful. They also break it down by unit, so you can see the resistance rates in the MICU compared to other units in the hospital, which is kind of interesting. I know you guys have to talk to your ID attendings about getting access to that because we get it through some of our pharmacy people, but they're available. So I have this as a handout, so I'm just going to print it for you and give it to you. But in general, I kind of think it's helpful to talk through what you guys think about. What are you going to start empirically in a patient, and what based on what bugs you're worried about? And then when you're on call in the middle of the night and your patient has decompensated, what organisms are you missing on current coverage so you know possibly how you want to expand. So that's kind of how I like to approach ID in the unit. Lots of times, obviously, we're using broad spectrum agents empirically and then hopefully de-escalating based on culture data. but there is some rhyme or reason to why people always end up on vancomycin. Like, it's not just because that's our favorite drug of choice. But in general, it's good to kind of think about, why did you start vancomycin, and do you still need it at this point? So in general, I like to lump together the beta-lactams and then your MRSA active agents, and then fluoroquinolones and aminoglycosides, and then colistin flagellar, just kind of there. But in general, empirically, you're going to start patients in the unit on pip/tazo, cefepime, or meropenem, and for good reason. You can see they have big, broad coverage. The things that you need to know about specific to each of those agents. So pip/tazo is not going to penetrate the CNS, so please don't use it empirically if you're worried about CNS infections. But other than that, you can use it empirically for just about anything. It's going to have good anaerobic coverage, good gram-negative coverage. It's going to cover VRE potentially, as well as MSSA and strep pneumo. Cefepime, in contrast, what it's going to miss compared to pip/tazo. So it's not going to cover enterococcus. Actually, no cephalosporin covers enterococcus. So if you're worried about some sort of enterococcal infection, please add something to your cephalosporin. It's going to have good gram-negative coverage, but it's not going to have anaerobic coverage. So if you are also worried about anaerobes in that same token, please add something. Cefepime penetrates CNS, so you can use it empirically for just about any infection. It will be fine. Meropenem is our carbapenem of choice. So, but depending on where you go, you might use other carbapenems. But in general, meropenem has probably the broadest coverage of any of the beta-lactams. So we try to not use it empirically unless we need to. It is going to add basically your additional gram-negative coverage for things like ESBLs, KPCs, Pseudomonas. So that's something to consider. It is going to have anaerobe coverage, so it's good for those infections that you worry about that. And it does penetrate CNS as well, so you can use it for empirically just about any infection. I put ampicillin, sulbactam, or Unicin on there just because we often forget about it because it doesn't cover Pseudomonas at the end of the day. So we never consider it for any type of healthcare-associated or hospital-acquired infection, but it's a perfectly reasonable option for things like community-acquired aspiration based on what it covers. So I just kind of listed there for your reference. And then remember, as Trinam, we include because this is your one beta-lactam that is not going to have cross-reactivity with a penicillin allergy. So this is your absolute go-to safest option for anybody that you're worried about anaphylactic reaction to a beta-lactam. The thing to remember about S-Trinam is look at that coverage. It only covers gram-negative organisms. It has absolutely no gram-positive coverage. So you need to add something like Vanco or something else if you need to have some sort of gram-positive coverage. Questions about the beta-lactams? All right, so then we move on to Vanco, Dapto, linezolid. So these are sort of your MRSA active agents. So we start everybody almost exclusively on Vanco, but that's understandably so. It's still the treatment of choice for most MRSA infections. What you're going to find is it obviously has no gram-negative coverage, and then it really doesn't cover many anaerobes except like C. diff, obviously. So if you're worried about MRSA, add it, and then you can always de-escalate if you need to. If you have an active MRSA infection and they fail to respond to vancomycin, that's typically when you start to get into agents like daptomycin or linezolid. The other option or caveat that you're going to try to use these drugs in is a VRE infection that's AMP resistant. So daptomycin, pretty much similar coverage to Vanco, but it will add that VRE coverage. Just remember with Dapto, you can't use it for pneumonia because it penetrates the lung, but unfortunately gets confused by the surfactant, and surfactant inactivates it. And then with linezolid, remember that it has similar coverage, covers VRE, but it is bacteriostatic versus daptomycin is bactericidal, so may or may not be important depending on what type of infection you're treating.
So it's the same as Dapto in terms of coverage, but you can use it for pneumonia.
Exactly. So you can, exactly. And actually there's some data arguing that maybe linezolid is better than Vanco for MRSA pneumonia.
And linezolid is the one that has a PO option.
Exactly.
Supposedly is
Yep.
good.
Yep. Yeah, so you can send patients home on PO linezolid if insurance covers it. When you order linezolid now and some of the other antibiotics, it actually is an order panel and prompts like a case manager consult. just to anticipate outpatient coverage.
Yeah, there's some attendings that came from other places that I worked with on GenMed, and they were like, what? I used to do Lenny's with PO all the time, and it
Yeah.
was so difficult.
Yeah.
to get.
Depends on your patient population, of course. But yeah, it's a reasonable option. Okay, so then fluoroquinolones, when are you going to typically add those? So think of fluoroquinolones. I know people always divide them by like above the belt and below the belt fluoroquinolones. But so you have respiratory quinolones and you have non-respiratory quinolones. So moxi and then levofloxacin are both respiratory quinolones. Why is that? Because they cover strep pneumo. It's not to say you can't use Cipro to treat a pneumonia, because it does penetrate the lung, but you're not going to use it empirically in a community-acquired pneumonia because you're going to miss the biggest organism you're worried about. But if you have a Pseudomonas pneumonia susceptible to Cipro, by all means, go for it. So that's sort of the dividing factor there. Quinolones cover atypical bugs, so if you're worried about an atypical pneumonia, that's kind of when you're going to start to add them. And sometimes people argue to add them as like double cover for gram-negative infections. That's like a whole talk in and of itself, but if you're going to double cover, fluoroquinolones might be an option. And then moxi is great because it does have some anaerobic coverage, so you can consider it for something like an aspiration, community-acquired aspiration pneumonia. If you need other atypical coverage and you don't want to use a quinolone, you could consider azithromycin, which is our macrolide of choice here. So it's going to have basically your classic community-acquired pneumonia organism coverage, not going to cover Pseudomonas, but again, good atypical coverage. Main thing to worry about with both quinolones and macrolides is QT prolongation, and I cannot emphasize that enough because I have had a couple of fatal torsades cases unfortunately happen in the hospital, and physicians look at me and wonder, how did that happen? And it's an additive effect, right? So you have to think about drug versus non-drug risk factors in the patients and what drugs you're adding and what's on board. But in general, if you're adding a quinolone or adding a macrolide to somebody's regimen, just think about whether they've had a recent EKG or not and consider it, because now it's actually a black box warning in the macrolide package inserts.
So if both of those are two of your first go-tos to cover atypicals, what's a non-QT?
Yeah. So then you start to get into things like doxycycline and some of the other tetracyclines. Yeah. But in terms of like better coverage and outcome data with like atypical pneumonias, your quinolones and your macrolides are definitely worth that risk. So you want to try to like come off of other agents. Like, can you treat the AFib something besides amio, or can you stop the Seroquel while they're on treatment of pneumonia, things like that. I put aminoglycosides in here. I know we have a voodoo against using them, but they do have a good role in terms of second double gram-negative coverage agent. So we do have all three of them available for use. In terms of dosing, I would just ask you to call a pharmacist, to be honest, because it depends on how your kidneys are, depends on what infection you're treating, and you want to make sure you're getting troughs and peaks or random levels at appropriate intervals. But in general, just call a pharmacist. And then I list colicin because unfortunately we're using it more and more. And then you guys also have the benefit of seeing lung transplant patients, which are often cystic fibrosis patients, and they always end up on colicin at some point during their life, just because of multi-drug resistant organisms. So it's out there, just be aware of it. But obviously it has a similar profile to aminoglycosides in that it only covers gram-negatives. And then flagel's a great thing to add if you need anaerobic coverage. The key at the bottom is there for your reference as well, whether or not it requires ID approval. If it does require ID approval, at what point? If it needs renal adjustment, where's the go-to reference? So you can hopefully try to follow that and avoid pharmacy pages in the future. All right, that's all I have. Sorry that it took forever. Any questions about